cardiologist and Associate Professor Cardiology, Senior Interventional Cardiologist at Ahmedabad. So what we are going to discuss today is an important aspect of delivering life-saving heart failure treatment. We all know that various concepts have emerged, including 4 pillars in managing heart failure, and that's what I'm going to touch upon with specific focus on how this can be applied to the common substrate of our population, especially in the Southeast Asia. Heart failure is a growing public problem with very high morbidity and mortality. It affects almost 64 million people worldwide. The heart failure hospitalization is number 1 cause of hospitalization across the world in patients who are more than 65 years of age, which is the aging population epidemiologically across the world. It is also projected to rise by another 50% over the next 25 years, which means it's going to stay as the number 1 killer across the world and number 1 cause of morbidity and hospitalization. If you look at the mortality, 5-year mortality in a patient of heart failure, despite an ARNI, is now 50%. Mortality significantly increases after each heart failure hospitalization with cumulative effect. This is a chart showing an insidious nature and the insidious start that this problem has from the first symptoms. But as the functional class deteriorates, every hospitalization leads to not only worsening of heart failure, but also increasing heart failure hospitalization and mortality. And this is on top of treatment of heart failure being instigated with each hospitalization and its intensification. If you look at the stage of at-risk patients from progressing from stage B to stage C and D, a lot of refractory heart failure patients at the end of the repeated hospitalization would end up in stage 4 class heart failure. So despite poor prognosis, there is of course lack of urgency from early identification because of multiple reasons at the level of inertia in diagnosis by the treating physicians or the cost of therapy coming in way to the patients actually if they are paying out of pocket to initiate the therapies that have been instigated. Over 40% of heart failure symptoms do occur up to 5 years prior to the diagnosis, and that's one of the reasons why a lot of times the therapy is initiated at late because of late presentation by patients themselves. 75% of those diagnosed with heart failure end up with unplanned heart failure hospitalization, and that's how the first point of contact often is the cause of initiation of these therapies. Guideline directed therapies in heart failure is often suboptimal. That means a lot of these patients may not be initiated on one of the 4 pillars as we understand, and over 30% of mortality is known to occur once a patient is hospitalized for heart failure hospitalization. So what are the guideline recommendations in these patients? The ESC guideline by 2021 recommendations talk about initiating dapagliflozin as one of the cornerstone of therapies for heart failure with reduced ejection fraction. They also talk about ACE, ARB or ARNI and the beta blockers apart from MRA, along with loop diuretics, which is only known to reduce symptom class but not improve outcomes in terms of mortality. However, the other class of therapies, including the dapagliflozin, is known to reduce mortality in patients with heart failure. Ejection fraction with less than 35% with QRS duration which is less than 130, ICD is recommended in ischemic as class 1 and in non-ischemic as class 2 recommendation. EF less more than 35 or device therapy when it's not indicated. If the symptoms persist, these patients can be further added other class of therapies. With however patients with QRS duration more than 130, they end up with CRT, especially as a class 1 therapy if the QRS is more than 150 milliseconds. Coming to the AHA ACC Heart Failure Society of America Heart Failure Guidelines, which now recommend SGLT2 inhibitor as a class 1 therapy in patients with reduced ejection fraction heart failure. When a patient with established heart failure with reduced ejection fraction, it's important to initiate GDMT, and they talk about all the 4 in the same breath, with SGLT2 mentioning it the foremost, along with beta blocker, MRA and ARNI, with level of recommendation class 1 with level of evidence as class A. In patients with FREF, SGLT2 being recommended to reduce heart failure hospitalization and also to reduce cardiovascular mortality, irrespective whether the patient has type 2 diabetes or not. Hence, when you look at the European Society guidelines for starting SGLT2 as a component of foundational therapy for all patients with heart failure with reduced ejection fraction, irrespective of patient phenotype, whether the patient is on SGLT2 with diabetes or no diabetes, or whether the patient has a CKD element, or patient has been hospitalized or not hospitalized across the spectrum, the SGLT2 along with beta blockers, ARNI, MRA and diuretics will form the cornerstone across the spectrum for the therapy to be initiated. We have some recommendations for the other, but for irrespective of patient has a bradycardia, tachycardia, hospitalized, non-hospitalized, diabetic, non-diabetic, CKD, non-CKD, across the spectrum, SGLT is one subgroup of drug or one pillar which is given blanketly without any contraindication. Now this all emanates from the very important trial called DAPA-HF, which looked at DAPA with the trial which was dapagliflozin in prevention of adverse outcomes in heart failure trial. The DAPA-HF trial included 4,744 patients, which included a non-diabetic subgroup, which was a bigger subgroup compared to diabetic subgroup. The median follow-up was just 18.2 months because it meant the strong endpoint much early as an anticipated with 1:1 randomization to DAPA versus placebo on top of standard care of therapy. At baseline, these patients had an NT-proBNP in the range of 1400 plus with ejection fraction mean of 31% and 55% were without diabetes with 41% with an EGFR below 60. When you look at the outcomes, you can see as early as 28 days with a net number to treat being just 21, the curve started diverging and became statistically significant. The composite of primary endpoint of CV death and worsening of heart failure was reduced by CV death or heart failure worsening by 26% with absolute reduction of nearly 5% with p-value of 0.0001. CV death was reduced by 18%, again reaching statistical significance, and so was worsening of heart failure with absolute reduction of 3.7%. All of them were independently statistically significant. All-cause mortality was the one important predictor and very important determinant which was also statistically significant, establishing this therapy as an unchallengeable therapy as a corner and pillar stone for managing heart failure. If you look at the adverse events, all of them were significantly more in placebo arm, primarily driven by volume depletion, driven by mortality, when the adverse event requiring discontinuation was not different between the placebo and the dapagliflozin arm. Now we know from the empagliflozin trials that it also in Emperor Reduce showed some benefits, but how the two trials are different is what I'm going to summarize in this slide. When you look at the heart failure hospitalization, yes, it's a class effect. You can have reduction in heart failure hospitalization across. But what about death? The CV death, I say, in heart failure, DAPA-HF has turned the tables on empagliflozin. Because the inclusion criteria were very different when you compare EMPA-REG versus declared TIMI. In DAPA-HF versus Emperor Reduce, the difference, despite more stringent criteria of recruitment in Emperor Reduce, the DAPA-HF with a non-inclusion criteria and a broad real-world practice-like scenario was still able to show CV death reduction by 18%, which was statistically significant, which was not the case with empagliflozin. All-cause death reduction was also by 17%, again was not significant in empagliflozin. New onset of diabetes in pre-diabetic population was reduced by 32%, which also was not there, but was only 14%, but not significant in empagliflozin arm. The change in the quality of life score or KCC calculated, DAPA was 6, okay, plus minus 16 versus placebo plus 3.3 plus minus 19.2, with the difference being of 2.8, while in EMPA it was 1.7, and hence calculated at 8 months for the dapagliflozin versus 52 weeks, which is 1 year of EMPA. Still DAPA had a slightly better quality life parameter as compared to EMPA. However, this is like comparing two different trials in a different subset, though we cannot compare them head on, but this is the primary difference. And when a molecule can show a mortality benefit, then nothing's more stronger in favor of that therapy as compared to the other therapy. What about the cardiorenal complications? When you look, there is a close association between cardiac and renal pathophysiology. Chronic heart failure leads to genetically predisposed patients worsening of the renal function, and this is often driven in huge extent in patients with low cardiac output with inflammation, arterial calcification and endothelial calcification leading to initiation and worsening of heart kidney damage. With the chronic hypoperfusion can lead to CKD and worsening and occurrence of kidney disease, which can further propensate and worsen heart failure because of anemia, metabolic abnormalities, and volume overload. Cardiorenal connectors like RAS activation, oxidative stress, inflammation, and sympathetic nervous system activation are some of the modulators that affect both individually and independently. The DAPA-CKD was one of the largest trial in CKD population, and this is the first and the only SGLT2 for patients with CKD with or without diabetes, which showed that the cardiorenal outcomes were improved, and so was the mortality reduction in the landmark trial. The DAPA-CKD had 4,000 plus patients against the placebo arm, and it showed 39% relative risk reduction in a composite of more than 50% eGFR decline, end-stage kidney disease, or renal or CV outcomes, with net number to treat very small of just 19. Remember, in these patients also 68% were diabetic while 32% were non-diabetic. All-cause mortality was reduced by 31%, and the kidney outcomes were reduced by 44%, while heart outcomes were reduced by 29%. Hence, this therapy has shown that this is the first and the outcome study to show all-cause mortality being reduced in patients with or without diabetes in a patient who had CKD. Also, with DECLARE, when you combine, you can look at the additional benefits that you can derive across the spectrum of diabetic kidney disease patients in terms of event reduction. DAPA-CKD, when you compare with the EMPA kidney trials, you had 39% relative risk reduction with a net number to treat just being 19, while EMPA kidney had 28% relative risk reduction. When you look at the secondary outcome in DAPA-CKD, all-cause death was 31% relative risk reduction, which was not statistically significant in EMPA kidney trial. Composite of CV death and heart failure hospitalization was also significant again in DAPA-CKD, recapitulating and replicating its outcome like DAPA-HF in DAPA-CKD. So, do adding therapies of heart failure, reduced ejection fraction treatment and its sequential initiation, do they have an evidence, or are they significantly outcome based driven or not? So when you combine the foundational therapy, you can actually extend the life of patients by almost 6 years. When ARNIs had come, people talked about 1 or 2 years. Now, but when combining the ARNI beta blocker, MRA and SGLT2, you are adding 6 years to these life, as was documented in this paper by Milton Packer's group. When you look at this therapy, the therapy is from the event-free survival in patients whose age, when you take off, when these patients are more than already 65 years of age, the survival is more than 6 years. So even younger patients, it may be even more. The limitation, however, is that when you initiate them step by step, you can actually lose out on patients, and you don't get benefit of these therapies being initiated with so many titrations and so many follow-ups. Hence, in our part of the world, a lot of these patients do end up getting initiated on multiple pillars at a time. The conventional sequencing of initiating reduced ejection fraction by the order of ACE followed by beta blocker, followed by MRA and ARNI, and then SGLT2, hence does not hold true, because the therapy that is known to reduce mortality must be initiated very early. So the conventional approach has a problem in delay in starting. The demonstrated reduction of mortality within 30 days therapies like an SGLT2 being delayed to the fifth pillar is no more acceptable. This assumes that the most effective and well-tolerated treatments were developed first, and assumes that the foundational therapies are effective and titrated to the targeted dose. Hence, the new proposal by Milton Packer and McMurray's group is also talking about the new expert proposal of sequencing the heart failure with reduced ejection fraction to be completed in 4 weeks. They talk about adding beta blocker and SGLT2 as the first simultaneous initiation, with ARNI initiated within 1 to 2 weeks and an MRA in another 1 to 2 weeks. However, a lot of times patients are initiated in our part of the practice all of these therapies at one go, if you can get a compliant patient with no exclusion criteria. And most of these patients do tolerate well, and of course dapagliflozin does not require any tailoring of the dosage. You start 10 milligrams across the spectrum. You can titrate the rest of the therapies as you may see the patient when you initiate them or on follow-up. So can generics be considered equivalent to the innovator? Now that's the other problem. In our part of the world, it's just the pharmacokinetics which are equated, not the pharmacodynamics to be per se. The original trial is the only molecule, which is the original brand, which is initiated to show mortality reduction or morbidity reduction. The other therapies that are initiated will only look at the serum levels of the molecule being achieved, and that also with a caveat of non-inferiority or bioequivalence, which may vary from the pharmacological serum levels in a range rather than being 100% equivalent to the original brand. The drug development process, as we know, runs from the discovery and preclinical studies to clinical studies from phase 1 and 2, with out of almost 5,000 to 10,000 new chemical entities boiling down to one phase 4 or 1 to 2 drugs after the regulatory review of 1 or to 2 years and post-marketing surveillance for the lifetime. And hence, the India submission of FDA or indigenous submission to European regulator would take almost a molecule to come into practice as long as around 6 to 10 years before they hit the market. And that's the problem, that the drug development is a long process of 10 to 15 years, amounting to between 800 to almost $2 billion to get a new drug to the market. And hence, pharmaceutical equivalence does not mean bioequivalence. And bioequivalence, whether it equates to therapeutic equivalence, is anybody's guess. A mere bioequivalence of a generic may not necessarily lead to same therapeutic effect in pharmacodynamics as the innovator, because what you have tested is only whether the serum levels of the two drugs are equal or not. Without an outcome-based trial, it's just an assumption that if the serum levels are same, the drug may be same. But this has a lot of problem with it. Bioequivalence, as I said, would range for a serum level between 80 to 125%. So a molecule which is 8.1 milligram of dapagliflozin versus some other molecule which is 12.5 milligrams of dapagliflozin would be considered to be bioequivalent for somebody who's taking 10 milligrams if the serum level is in that range. And hence, generic bioavailability may range from minus 20% to plus 25%, which is difficult to measure in a progressive chronic disease like heart failure. So why to take a chance in patients suffering from complex cardiorenal metabolic disorder and you don't know whether you are going to achieve the same bioequivalence or the therapeutic goals that what you target to do. You're not chasing patient to achieve same serum levels, you're chasing the patient to prevent its death or even worse outcomes. So original DAPA does have an elaborate drug development process, BABE studies on sick patients, number of subject tested are thousands to lakhs. Expedient is globally approved one which can vary from the generics. Source of raw material is single manufacturing unit with efficacy in randomized controlled trials with safety being followed all across despite within vigorous post-marketing surveillance. Compared to innovator statins, the probability of suffering a serious adverse event or CVE for generic was higher by an average 31%. This is just one example why bioequivalence may not translate into safety. Looking at the dapagliflozin to transform patient outcome by providing life benefit, hence DAPA is recommended not only as the therapy for reduced ejection fraction, but it's one of the first pillars of GDMT must include based on the DAPA-HF, which significantly showed benefits in primary composite outcome across the subgroup with 18% relative risk reduction in CV death with 17% relative risk reduction in all-cause mortality. DAPA-CKD demonstrated 31% relative risk reduction in all-cause death, and that's the strongest parameter to choose a therapy. If anything can prevent a death, that therapy heart failure, irrespective of diabetes or not, across the patients of CKD, because the burden is strong. The debate is now switching from what there was once a editorial, shall we add statins to pipeline? Maybe I would say, shall we add SGLT2 to our water pipelines? Because SGLT2s are emerging as therapy across the class in patients with diabetes or without, in patients with CKD or heart failure. And that's what will translate only in a brand or a molecule of the original innovator that has shown mortality outcome reduction. Thank you very much.